Good evening and welcome to today's clinical seminar on differentiating bipolar disorder from ADHD. My name is Elizabeth Errico, and I am the Executive Director of CMHRC, the Children's Mental Health Resource Center. My clinical coordinator, Jennifer Sevick, is here with me tonight, and she will be answering your questions in the Q&A as we go. For those of you who are new to CMHRC, our mission is to provide guidance and resources for early identification and management of mood disorders, bipolar disorder, and bipolar's newly identified phenotype, which has been dubbed by researchers fear of harm. We fulfill this mission by providing a number of different programs and services to families as well as providers. We offer parenting classes. We have a web app that we have developed for providers and families to use in order to track symptom, medication, and mood management interventions. We have a book club that meets once a month in which both providers and families get together to discuss books related to mental health. We have a lot of diverse uh, types of books that we read for our book club, everything from nonfiction to workbooks to fiction. In April of last week, we had a discussion on the book Brainstorm From Broken to Blessed on the Bipolar Spectrum with the author, Sarah Schley. In coming up in July, we are going to be having a special book club session with Dr. Georgia Ede, the author of Change Your Diet, Change Your Mind, where she talks about the use of metabolic interventions such as the ketogenic diet in order to change your symptoms of mental illness. So you can check out that on our website. We also have professional development discussion groups for providers to come together to discuss complex cases and get peer supervision and support from other providers on the difficult cases that you wrestle with. We also have custom support services for families and providers, including diagnostic consultation and collaboration, mental health education for school, and transition support services when families are changing a provider. We do all of this work that we do as a nonprofit, and we rely on the generosity of our community to support our work and to subsidize costs for families and providers, such as this free webinar and seminar tonight. So we are approaching May when we are having our first fundraising campaign of the year in honor of Children's Mental Health Awareness Month. So if you benefit from our programs and services, such as I said, this free event tonight, please consider making a gift to support our work to ensure that everyone has access to the services that they need, not just those who can afford to pay for private services. So tonight we are here to discuss the difference between bipolar disorder and ADHD. There's a lot of discussion in the community on concerns that perhaps bipolar disorder is overdiagnosed. We touched on this last month in our clinical seminar on bipolar disorder in childhood, what its symptoms are and how to recognize it. Because the reality is that children are being misdiagnosed with other diagnoses instead of bipolar disorder. In fact, NIMH estimates that 1/3, more than 1 million children and teens who are diagnosed with major depressive disorder are actually suffering from bipolar disorder. And one of the common misdiagnoses, in addition to major depression, is ADHD. Now, we are not here to say that all children who have ADHD have been misdiagnosed. In fact, quite the contrary. What we're saying is that these are two distinct diagnoses that are different for one another. However, because there is symptom overlap, there's confusion over which is which. And so the important thing is for a child to be diagnosed accurately. And so we're here to talk about the differences so that we can facilitate that accurate diagnosis, be it bipolar or ADHD. So we're going to be looking in depth at two papers that have been published in peer-reviewed journals. The first is called Neuropsychological Factors Differentiating Treated Children with Pediatric Bipolar from Those with Attention Deficit Hyperactivity Disorder. The authors on this paper are Dr. Stephen Mattis, who is a PhD neuropsychologist, and Dr. Demitri Papolos, who is a child and adolescent psychiatrist and the author of the book, The Bipolar Child. He's considered to be one of the world's leading experts on juvenile onset bipolar disorder, and he's the research director at the Juvenile Bipolar Research Foundation. Coming up in May and June, we are going to be doing a very special webinar series with Dr. Papolos, where he will explain the history of the identification of the phenotype of bipolar disorder called fear of harm. And he will be discussing not only the development of the diagnosis, but also the development of successful treatments, treatment protocols, and doing live Q&As with our audience. So you can check out our website and our social media pages for information on that. The second paper we're going to be looking at is called Diagnosing Bipolar versus ADHD by Dr. Charles Popper. Dr. Popper is a physician and a lecturer at Harvard Medical School's McLean Hospital. He is a child and adolescent psychiatrist and a psychopharmacologist who has treated countless children and families in his practice over the last 50 years. So before we start talking about differentiating these two disorders from one another, we are going to stop for a moment and talk about differentiation in general, because the structure of the DSM, how it was developed, how it is designed to be used, significantly impacts how we understand and view mental health disorders. So we all know that the DSM was designed to classify observable signs and symptoms into different diagnoses. And it was created this way in order to simplify the process of diagnosing and to help providers who were in different locations and at different types of institutions communicate effectively with one another around the disorders that they were treating. These characterizations of symptoms are based on how they cluster together. And it created a common language for practitioners that focused on, again, observable behaviors. And those clusters were then given names so that a clinician, as I said, in one part of the country could talk with a clinician somewhere else, and they would know that they were talking about the same thing when they used a specific diagnostic term. Honestly, the history of the DSM is a lot more complicated than this, and we do a seminar on the history of the DSM and how it can actually sometimes cause more trouble than and cause more problems than it solves. And that's coming up later this year. Check out our website for information about when that will be happening. But for now, let's focus on this symptom clustering model. The DSM diagnoses are lists of symptoms and criteria. And in order to qualify for a specific diagnosis, a patient needs to show some sort of majority of those symptoms. But a simple explanation of the challenges that the DSM has is that many symptoms appear in multiple diagnoses. And so the result is that the boundaries between these diagnoses are somewhat porous, and which makes it hard for them to be differentiated from one another. This is why, in order to differentiate two different diagnoses, for example, bipolar and ADHD, clinically, we have to look at not just what the symptoms are, but how and why they're manifesting the way that they are. So again, tonight we're going to start with a brief look at some very concrete and testable neuropsychological differences that are uncovered during neuropsychological testing. So in this particular study, the researchers looked at comparing 3 different populations of children, ones with bipolar, One's diagnosed with ADHD, and one's diagnosed with both bipolar and ADHD. And they looked to compare them on measures of reaction time, processing speed, and motor preparedness. And in order to make these comparisons, they gathered data from a lot of different assessment measures covering areas that included general intellectual ability, academic achievement, attention, memory, language, and executive functioning skills. So, this is a wide, diverse range of neuropsychological factors that were being included in this assessment. The study authors suggest that when treated, each diagnosis or combination of diagnoses shows identifiable differences in their pattern of neuropsychological strengths and weaknesses. The first finding that they reported was that children with bipolar disorder and children with bipolar and ADHD performed significantly worse on all of the measures of processing speed than the children who just had a diagnosis of ADHD. This indicates that slow processing speed may be a trait or feature of pediatric bipolar disorder. Finding 2 shows that the intra-individual variability in pediatric bipolar disorder was greater than that which was found in patients with just ADHD. This means that short-term fluctuations in behavior, ones that don't represent systemic behavior changes, were much more prevalent in pediatric bipolar, which again supports the contention that intra-individual variability is a core feature of pediatric bipolar disorder. Finding 3 indicates that the reaction time is differentially longer and more variable in children with bipolar as compared to children with ADHD. As the time interval between stimuli lengthened, the time it took them to react both lengthened and became more variable, indicating that kids with bipolar disorder require longer processing time than children who are only diagnosed with ADHD. Finding 4 shows that the measures which directly assessed impulsivity did not differ among the 3 groups, indicating impulsivity is consistent across the 3 groups assessed for the study, and that impulsivity cannot be used as a differentiating factor in determining bipolar versus ADHD. Finding 5 showed that children with ADHD performed well on all neuropsychological measurements as compared to the children with pediatric bipolar disorder. Finding 6 showed that overall, children with bipolar disorder and ADHD performed more poorly than children with only bipolar and only ADHD. And they were statistically poorer on measures of fluency, rapid automatized naming, and single word reading. Finding 7 indicates that children with bipolar disorder, when stable and compared to treated children with ADHD, still performed more poorly on the WISC-4 measurement of processing speed and on measures of response preparedness and intra-individual variability on reaction time tasks. These 7 findings led the researchers to suggest that identifying characteristics for pediatric bipolar disorder versus ADHD include slowed processing speed, elevated intra-individual variability, longer and more variability on reaction time, and a slowed response preparedness. But the authors also noted that even when appropriately identified and treated, children with pediatric bipolar children with pediatric bipolar and ADHD, or those with only ADHD and no mood disorder, all have different clinical needs. And therefore, the practical implications of these findings wind up being somewhat different for each group. And I just want to pause here and point out something very important. A lot of times in the discussion around bipolar and ADHD, what we hear is folks saying, well, before you diagnose something as serious as bipolar disorder, a disorder like ADHD needs to be considered. And we will talk more about that in a moment when we talk about Dr. Popper's paper on differentiating the two. But for now, what I want to mention is there is nothing, as this study shows, that means that children cannot have both ADHD and bipolar disorder. So it is not necessarily always a choice between the two, but it is entirely possible that children can have multiple diagnoses at the same time. Now, the authors tell us from a clinical standpoint that, as you would expect, when children are treated properly for bipolar disorder, there's a significant reduction in behavioral disruptions and mood-related issues. However, even with successful treatment for those behavioral disruptions, cognitive disorders and disruptions still continue for those kids who have bipolar disorder. And these disruptions result in atypical behaviors, both at school and at home. So kids with bipolar need additional therapy as well as additional special education accommodations and interventions in order for them to be able to succeed at school. And for kids with both bipolar and ADHD, even when treated, they continue to struggle with verbal fluency when compared with children treated only for bipolar disorder. So it makes sense to evaluate children with bipolar and ADHD for reading and other academic difficulties. But this leads the authors to caution us that when children with ADHD who are receiving treatment continue to demonstrate cognitive deficiencies, that should raise a red flag that further evaluation is required to see if a mood disorder is present or possibly in a prodromal phase. Now, we've touched so far on focusing on neuropsychological testing, which is not something that all mental health professionals do. So it may not feel applicable to everyone's clinical practice. So what we're now going to do is move into taking a look at a more sign and symptom-based differences between bipolar and ADHD through a detailed look at Dr. Popper's 2015 paper called Differentiating Bipolar versus ADHD. And he identifies characteristics that are present in both disorders. And he gives us some very solid descriptions of how, when falling under the same symptomatic umbrella, they can be differentiated from one another in clinical assessment. So, similarities between bipolar and ADHD, according to Dr. Popper, include such items as impulsivity, inattention, hyperactivity, physical energy, behavioral and emotional lability and frequent changes, frequent coexistence of oppositional and defiant behaviors, learning problems, motor restlessness during sleep, and family histories of mood disorders. And in his introduction, lest we be hard on ourselves for the challenges that these similarities pose in diagnosing, Dr. Popper reminds us that in view of these similarities, it is not surprising that these disorders are hard to tell apart. So, to help with that differentiation, his paper identifies 15 characteristics or features that can be used to distinguish between these two disorders. And we're going to look at each of those now. Again, I want to encourage people to put your questions in the chat. Jennifer, my clinical director, is answering questions. She's also going to be saving some for the Q&A live at the end. So the first of the characteristics that is in the overlap is destructiveness. Destructiveness is seen in both bipolar disorder and ADHD, but importantly, it differs in its origin. Children with ADHD often break things carelessly while playing. But in bipolar disorder, typically destructiveness is not a result of carelessness, but it tends to occur during episodes of irritability and anger. That can include severe temper tantrums. It can include manic quantities of physical and emotional energy. It can involve manic quantities to that physical and emotional energy and also violence and intentional property destruction. It's not just whether or not the child breaks things that matters. From a clinical standpoint, we need to be looking at whether or not it was carelessness or done out of anger. Was it done accidentally or intentionally? Did it happen during a moment of calm, or did it happen as a result of a tantrum? Now, angry outbursts do occur in both disorders and in childhood in general. We don't want to suggest that they don't, but the duration and intensity of those angry outbursts and temper episodes differ significantly between these two disorders. Children with ADHD usually calm down within 20 to 30 minutes of the disruption, and the level of physical energy that's used during their tantrum feels relatively expected, or as Dr. Popper says, could easily be mimicked by an adult. But in children with bipolar, these tantrums and aggressive, angry feelings may continue much longer than 30 minutes. In fact, they can last sometimes up to 4 hours. Additionally, the amount of physical energy that is generated during a tantrum for a child who has bipolar disorder could not be imitated by most adults who would reach a point of physical exhaustion within just a few minutes. Regression is a relatively rare phenomenon in ADHD. And during angry episodes, kids with ADHD are unlikely to display disorganized thinking, disorganized language, and disorganized body position. However, all of these things are common when children with bipolar disorder are having tantrums. They may, in fact, lose memory of the tantrum and afterwards not even remember that it happened at all. Many parents describe their children who have bipolar having tantrums as though their eyes have gone blank. They use the words, their children are not there behind their eyes and while they're raging. And after, quote, coming out of the rage, they'll be pleasant and not appear initially to be remorseful because they don't remember what has happened or what they did. Now, the triggers for temper tantrums are also different between bipolar and ADHD. ADHD tantrums are typically going to be triggered by sensory overload or affective overstimulation, such as, unexpected or unprepared for transitions or hurt feelings. Usually the triggers for ADHD tantrums, just to sort of put it simply, the adults around them, once they know what to look for, can identify that there was a sensory overload, that there was something going on with their ADHD symptoms. Now, with bipolar disorder, on the other hand, children with bipolar typically react very negatively to limit setting. Often something as simple as a parental no, a denied request by a parent or a teacher leads to significant conflict with authority figures. A child with bipolar disorder might even seek out this conflict with authority figures if they feel wronged or feel frustrated or feel thwarted. Um, And again, it's not just whether or not the child has tantrums. We want to be looking for three tantrum related characteristics: the duration and intensity. How long does the tantrum last? How intense is it? What is the energy output that that tantrum is requiring? Does the child stay lucid, aware, and responsive during the tantrum? Do they remember what's happened after the tantrum has ended? And can they accept limits, or do they appear to seek conflict? Perhaps one of the easiest of the characteristics between ADHD and bipolar in order to differentiate is mood, because fundamentally bipolar disorder is a mood disorder and ADHD is not. This means that while in both cases of ADHD and bipolar disorder, the moods may change quickly, the difference is that children with ADHD do not generally show any signs of depression as a predominant symptom. Additionally, kids with ADHD don't tend to have developmentally abnormal difficulty waking up in the morning or becoming alert and oriented after waking. They tend to arouse quickly and attain alertness within just a few minutes. But children with mood disorders often experience chronic irritability, which is a sign of depression in childhood, especially with those who have bipolar disorder. And irritability with high energy can be a symptom of mania in bipolar disorder in children. In the morning, kids with bipolar disorder also struggle mightily with levels of arousal, and they experience an extended period, sometimes as much as several hours during the morning, of irritability and dysphoria, fuzzy thinking, or cobwebs in their mind. And they report specific somatic complaints such as stomach aches and headaches. And kids with ADHD do not do that, generally speaking. Like mood disruptions, sleep is an area where kids with ADHD and those with bipolar disorder differ markedly. For kids with ADHD, they may have difficulty reducing distractions so that they can get to sleep at night. But in bipolar disorder, sleep disruptions can be severe and include horrible nightmares, which often contain explicit gore, mutilation, and inescapable violence. Children with bipolar disorder are also more likely to routinely experience multiple awakenings each night or have fears about going to sleep, both of which may be related to the dream content of their nightmares. Again, themed with pursuit, abandonment, violence against themselves as well as against people that they love. So when you're looking at mood and sleep to differentiate between bipolar and ADHD, you want to be looking for, are there signs of depression? And that includes chronic irritability. Is sleep disrupted at the onset, or is it also disrupted during the middle of the night and in the morning? And are there nightmares with violence and frightening imagery that might make children reluctant to go to bed at all? There are learning disruptions that are well known and documented with regards to ADHD, and children with ADHD often have co occurring specific learning disabilities. Children with ADHD also obviously have difficulties with attention and may not stay involved in activities, even if they're interested in like an awesome TV show, they may not stay engaged. They may not be able to follow the plot fully, or even stay in the room, especially if you're watching anything that has commercials. That is a moment where kids with ADHD will wander, and their minds will wander, they will physically wander, and they will cease to be engaged even if they're interested. But learning obstacles and attention issues in children with bipolar disorder are more likely than not the result of motivational challenges. Unlike a child with ADHD, kids with bipolar disorder are often unable to use motivation to overcome their inattention. They can stay tuned to an awesome TV show for long periods of time. Excuse me, I misspoke. I put a negative in that sentence that did not belong. Um, Kids with bipolar disorder are able to use motivation to overcome their attention issues in a way that kids with ADHD are not. A child with bipolar disorder can often use motivation to overcome their inattention. They can stay tuned to that awesome TV show for long periods of time. And alternatively, if they are not motivated to pay attention, there is no amount of cajoling, persuading, uh, or as one provider I know describes as tap dancing, that can alter that inattentive outcome. Children with bipolar disorder also often show giftedness in certain cognitive functions, especially verbal and artistic skills, often as early as ages 2 or 3 years old. Now, this is not to say that children with ADHD cannot also be gifted. Of course, that they can. But when putting together a matrix for differentiating symptoms, it is worth noting that this is something to be on the lookout for. Very early giftedness in verbal and artistic skill sets. Now, Dr. Popper's list addresses one area that you are, as the clinician, guaranteed to witness yourself, and you do not have to rely solely on parental reports, and that is the clinical interview. In an interview setting with children with ADHD, they are more likely to be pleasant and or generally speaking not hostile at that first meeting. And if they're in a noisy location, they may immediately show signs of hyperactivity, inattention, and impulsivity. They might get frustrated, they might get bored, they might be more impulsive, but usually when this happens, they won't go so far as to uh, direct any challenge or aggression towards the interviewer. However, for children with bipolar disorder, they are, during that initial clinical interview, often going to appear outwardly uneasy, unhappy, hostile, or even outright reject the interview or the interviewer within a few seconds of meeting the interviewer. Children with bipolar can often be described as interview intolerant, and they try to disrupt or get out of the interview, asking repeatedly when the interview is going to end, by insulting the interviewer, by becoming verbally aggressive with the interviewer, or even by leaving. Now, Dr. Popper uses the term misbehavior, and I have made the decision, we at CMHRC have made the decision to put the word misbehavior here in quotes. Dr. Popper does not do that in his paper. We do, because we balk at the use of the word misbehavior to describe a child who is experiencing symptoms of a mood disorder or any mental health disorder for that in that case. However, this is the language that Dr. Popper uses in his paper, so we will use it, but we've put it in quotes and added an asterisk as a reminder that what we're really talking about here for kids who have mood disorders and bipolar disorder is a symptom, not a misbehavior. It is something involuntary that they are experiencing as the result of the disorder, not something that they are intentionally choosing to do as a behavior. So, with that said, Dr. Popper asserts that in ADHD, misbehavior is often accidental. The example he gives is that if they crash into a wall or some kind of limit from an authority figure, so a literal or metaphorical wall, it's often due to obliviousness, inattentiveness, being unaware that the wall exists or that the limit is being set. But the child with bipolar disorder is more likely to crash into that literal or metaphorical wall with intent and for the sake of challenging its presence. Children with bipolar disorder are highly aware of that literal or figurative wall, and they are aware of exactly how to challenge it. Oftentimes, though, and I really want to underscore this, children with mood disorders and bipolar disorder specifically, when they're experiencing involuntary symptoms, become provocative in this way, where they are aware of, sensitive to how to get the biggest reaction, how to put forth the biggest complicating challenge to the limit that or wall that has been placed in front of them. But they're not really sure why they're doing it. And they can't seem to stop themselves, even though they don't want to be doing it. And afterwards, when asked, why did you do that? They don't have a reason. And when they say, I don't know, there is a tendency amongst providers, parents, and teachers and other authority figures to assume the child is being evasive, to presume that the child is being untruthful, and that there absolutely had to have been a reason for them to have behaved that way. And we really want to underscore that when a mood disorder or bipolar disorder is what's being is the cause of their behaviors, it is not voluntary. They don't know why they've done it. And very often, when they can remember it, are extremely remorseful that they engaged in that behavior in the first place. And that can lead to shame, humiliation, and low self-esteem. Risk taking is another factor that is included in both ADHD and bipolar disorder. Overall, intentional risk taking from a child with ADHD is fairly low. They may stumble into a fight or conflict. They may engage in some self-endangering behavior without really noticing the danger. They just sort of impulsively rush headlong into a dangerous circumstance. And these risks are being taken fundamentally out of inattentiveness. But on the other hand, the child with bipolar disorder will often seem as though they're looking for conflict, that they are somehow perhaps even enjoying the power struggle. Parents and teachers describe that all the time, and they attribute it with intentionality and purposefulness and willful behaviors by saying, well, obviously he was looking for a fight. He was engaging in a power struggle with me on purpose. But what's happening very often for kids who have bipolar disorder is that danger that they're experiencing when they're risk taking is providing some sort of positive or at least positively experienced mood impact. It is worth noting, however, that children with bipolar disorder very often have significant phobias. Needle phobias are not uncommon. Fear of the dark, a phobia about strangers, all of these things can be a component of the mood disorder piece, which will temper when and how daredevilish quote behaviors might take place. I saw a hand raised. Please go ahead and put your question into the Q&A. Jen will answer it now, or she will hold it to the end for the live Q&A session if she sees that multiple people are asking the same question. Kids with bipolar disorder can also experience danger seeking as a symptom of grandiosity. They feel invincible. They experience the challenge as not a challenge. They are demonstrating their mastery over their environment and demonstrating their superiority. So when danger seeking and risk taking is happening in a way that seems to be inflating an artificial sense of superiority or self-esteem, it can be identified not as the impulsiveness that goes along with ADHD, but in fact the grandiosity symptom of bipolar disorder as it manifests in children. In addition to danger seeking, specific to bipolar disorder as opposed to ADHD, and often present in early childhood, very early, the preschool years, and will persist into adolescence and adulthood, are these emerging patterns of energized giddiness, giggling, hypersexuality, hypersexual awareness. And again, these factors evolve through early childhood and into adulthood. And as we discussed last month in our seminar on bipolar disorder and its presentation in children, we do talk about the fact that certain sexualized behaviors may not appear as such in childhood and evolve over time into something that is more quickly recognizable as some sort of hypersexualized behavior. If you're a member of CMHRC, you've had access to that March clinical seminar all throughout the month of April. If you're not a member, it will be made available on our YouTube channel on May 1st next week. So the takeaway about behaviors is not whether or not the child struggles with inattention or impulsivity. It's how much they challenge authority, according to Dr. Popper. So you want to be looking for things like, do they act in a hostile way? Are they challenging? Are they insulting to authority figures? Are they aware of boundaries? Are they intentionally, and again, I'm putting that in quotes, Dr. Popper didn't, but are they pushing those boundaries with knowledge that they're pushing those boundaries? Do they seek out conflict? Does having a fight provide some sort of mood impact that they're seeking? And is there any form of hypersexuality? Now, the course of the illness between ADHD and bipolar is also important to examine. The natural course of ADHD, as it is understood, is that it is a chronic and continuous disorder. But when treated effectively, it tends to improve over time. Appropriate interventions, age, medications, accommodations, all come together as a complete treatment plan that allows for improvement over time. There may be periods when symptoms worsen due to specific circumstances like increased stress, but generally speaking, ADHD arcs towards improvement. Bipolar disorder, on the other hand, may or may not show clear episodes of cycling. We say that by its nature, bipolar disorder is a cyclical disorder, which means that symptoms will become more severe, more pronounced, more dramatic over time, and they will dissipate as well over time. And those two things happen in ways that do not necessarily have distinct, externally identifiable triggers, such as stress. They may be entirely internally driven based on the biology of the bipolar disorder. And over the course of years, without treatment, bipolar disorder is progressive. and it will continue to intensify over the years. Now, there are particular periods of danger for bipolar disorder as symptoms increase and the child grows larger and stronger, and their impulsivity becomes more difficult to contain, which is one of the reasons why it's extremely important to be able to accurately make this differentiation as early as possible. Now, similarly to regression, children with ADHD do not show signs of psychosis unless there is a co-occurring psychotic disorder or a disorder that has the potential for psychosis, like depression, like prodromal schizophrenia, or a substance abuse medication-induced psychosis, or there is some sort of psychotic grief response. So unless there's something specific, like one of those things listed, ADHD is not going to result in uh, exhibiting psychotic behaviors. Bipolar disorder, on the other hand, um, there are elements of psychosis that can be present when it's untreated. That includes gross distortions and misperceptions of reality or interpreting emotional events incorrectly. Those two things are very common in children who have bipolar disorder, and they may even experience as a symptom of the bipolar disorder paranoid thinking or sadistic impulses. The differences in the medications are also extremely clear and well documented, and researchers and clinicians who engage in treatment with patients recognize that a mood stabilizer, and that includes lithium, which is considered the gold standard treatment for bipolar disorder, and other mood stabilizers such as lamotrigine and oxcarbazepine generally improve bipolar disorder symptoms within a relatively short period of time of weeks or months if the titration process is slow. But these medications are going to have absolutely little to no effect on ADHD symptoms. A proven mood stabilizer may not be sufficient to address all of the symptoms of bipolar disorder all at once, especially if there are strong episodes of mania or psychosis. But a mood stabilizer is not going to cause any additional symptom activation in a child with bipolar disorder. It is going to help calm the symptoms. It will not calm the symptoms of ADHD. And this is really important. ADHD stimulant medications, such as Ritalin, which is in long-acting form as Concerta, its generic is methylphenidate, or Adderall, which its long-acting form can be found under the brand name of Vyvanse. These are the two most commonly prescribed medications for ADHD. They can activate symptoms of bipolar disorder. They can induce manic and hypomanic episodes. They can exacerbate bipolar disorder in destructive ways, such as triggering mixed states in which the child is experiencing the cognitions associated with a depressive disorder at the same time they are experiencing the elevated energy and grandiosity that goes along with a manic or hypomanic episode, which can lead during a mixed state to potential significant self-harm, suicidal ideation, and suicide attempts. So when a stimulant ADHD medication is used and a child responds adversely, including increased aggression, decreased need for sleep, hyperactivity, that is a red flag that it is not ADHD, it is in fact bipolar disorder, and that ADHD medication is activating and triggering a bipolar episode. So it is always best to err on the side of not assuming that symptoms that are present because of ADHD. Dr. Popper finally addresses the coexistence of ADHD and bipolar disorder by acknowledging the opposite, which we said a little while ago, that some children are going to have both. Some children are going to have ADHD and bipolar disorder, or ADHD and a unipolar disorder, such as major depression. And some children are going to have a combination of ADHD and bipolar disorder. And the fact that one exists does not necessarily mean that the other does not. Dr. Popper cautions us that because of the difficulty differentiating ADHD from bipolar disorder, a child who has either bipolar or unipolar disorders, but not ADHD, may have been misdiagnosed with ADHD because both of the disorders include inattention, impulsivity, and hyperactivity, which in bipolar may actually be hypomania, misinterpreted as hyperactivity. And his concern, keep in mind, Dr. Popper is a child and adolescent psychiatrist, a lecturer at Harvard Medical School. His concern is not that bipolar is being overdiagnosed. His concern is that ADHD is being overdiagnosed and bipolar disorder is being underdiagnosed in children and teens. And that aligns with the information I provided earlier about statistics out of NIMH and CDC, that roughly a third or more than 1 million children and teens who are diagnosed with unipolar or major depressive disorder are actually living with bipolar disorder. And Dr. Popper goes so far as to say that all of the features of ADHD can be seen in mood disorders. So ADHD is a diagnosis reached only after ruling out a mood disorder. But unfortunately, we don't do this. Most providers have been taught incorrectly that bipolar disorder is a rare unicorn disease that you will rarely, if ever, see, and that ADHD is a very familiar and commonly present disorder of childhood. According to the experts, the opposite is actually true. All the features of ADHD can be seen in mood disorders, so you have to rule out ADHD first. You have to rule out a mood disorder first before you can diagnose that more familiar diagnosis of ADHD. So how do we do this? We do this but we ensure that there's an accurate diagnosis and provide effective therapeutic and medicinal interventions by keeping a cheat sheet, if you will, on these differentiations in symptom presentation and in these neuropsychological factors that are different between the two, so that we can be on the lookout when assessing these kids and teens who are suspected of having ADHD. And you need a good tool to be able to help your clients, their parents, in many cases, track symptom presentation and tie it to the impacts of medication and the medication trials that are happening. And so we at CMHRC have built a tool for that. It is a specialized web app, which we call the CMHRC Toolkit, and it does exactly this. It allows patients and parents and providers to track symptoms, their prevalence, their intensity on a daily basis, and keep a log of medication history and compliance, including doses, their effects, how regularly they're taken as prescribed. You're able to maintain short narrative summaries of each day in terms of how the activities and events are going. It even records local weather, hours of sunlight, the phases of the moon. It is truly comprehensive, and it shares all this information in data and graphs that are accessible with a single click, so that you can keep track of overall mood stability with what we call the symptom severity index. And you can also get graphing of individual symptoms to see how they were impacted over time by specific medication interventions. So you can see whether or not a mood stabilizer is having an effect to reduce symptoms. If it is, then that's a clinical indicator that bipolar disorder is in fact the disorder that's being experienced. If the graphing of symptom presentation shows you that no, in fact, the mood stabilizer isn't doing anything, then that's a clinical data point that can be used to rule out bipolar disorder. The same is true for the introduction of ADHD medications. Um, this toolkit allows families to be able to track all of this on a daily basis, and professionals who have a toolkit account can let their patients know, and their patients can then select them and share their profile data with that provider so that you can see in real time what is happening with that patient when they are not in your office for your visit. Because we all know the old maxim that what we see as clinicians in the office is usually reflective of whatever happened on the car ride over. And so this gives objective data for providers to be able to view throughout the week to catch up on how your patient is doing outside of your sessions. Now, the toolkit exists for, as I said, for families as well as for providers. One of the special things about the toolkit account for providers is that we do not upcharge you for the patients of yours who use it. So a provider, you have one account that's like $14.99 a month, less than the cost of Netflix, and your patients you can have as many patients that you're tracking on there as you want, with no increased charge. And we offer special coupon discounts for your patients so that they can access the toolkit at a discounted rate while they are using it and working with you. Okay, so now that we've discussed these differences between the two diagnoses and the supports needed to be able to track symptoms, it's also crucial that we address the reality that there are real disparities between not only how we treat white versus BIPOC children in terms of mental health care access, but we also need to recognize that these disorders may be perceived differently in children who are white versus children who are BIPOC. So racial disparities, unfair differences within the system of mental health care are well documented. Research indicates that as compared to people who are white, Black, Indigenous, and people of color are less likely to have access to mental health care services. They're less likely to seek out services. They're less likely to receive needed care, more likely to receive poorer quality of care, and are more likely to end their services prematurely. BIPOC individuals are also overrepresented in the criminal justice system, as that system overlays race with criminality. The mental health crisis in the BIPOC community are often met with disciplinary or criminal justice responses than therapeutic ones. And we see BIPOC children all the time who are criminalized for having mental health challenges that manifest at school as well as in the community. Statistics show us that over 50% of those who are incarcerated have mental health concerns, which suggests that rather than receiving treatment for mental illness, BIPOC individuals are ending up incarcerated because of their symptoms. In jails and prisons, the standard of care for mental health treatment is generally low, and prison practices themselves are often traumatic and exacerbate pre-existing mental health conditions or illnesses. And those individuals who arrive in prison with one of those conditions generally find them to continue to be untreated. One of the reasons for these disparities in care is that the vast majority of mental health treatment providers in the United States are white. For example, approximately 86% of psychologists are white, and less than 2% of American Psychological Association members are Black. Some research has demonstrated that provider bias and stereotyping are relevant factors in healthcare disparities. And even after controlling for specific factors such as income, insurance status, age, and symptom presentation, racial disparities still exist and are established barriers for BIPOC individuals, including um, in the areas of perceptions around mental illness, help seeking, they have different help seeking behaviors. They have different measures of well-being. There is systematic racism and discrimination within the healthcare system. There is a greater vulnerability for being uninsured, and additional access and communication barriers exist in the form of fear and mistrust of treatment. One area that I think we don't talk about enough when discussing racial and cultural barriers to treatment is the traumatic historical context of systemic racism within mental health care and institutions of mental health care. Um, Even though it is well known and documented that race and insanity, I put that term in quotes, have a long and troubled past in the United States. A specific kind of systemic scientific racism was used to justify slavery, to appease the moral opposition to the Atlantic slave trade, and Black men were described as having, quote, primitive psychological organization, making them, quote, uniquely fitted for bondage. Psychiatric professionals and physicians, including those like Benjamin Rush and Samuel Cartwright, use the concept of mental illness as a justification for the perpetuation of slavery, including making so-called scientific claims that those who were free from enslavement suffered mental illness at higher rates than those who were enslaved. And the US Census even made this claim, and it was used as a political weapon against abolitionists. The Black psyche was increasingly portrayed as unwell, immoral, and inherently criminal, and this has helped to justify the need for police brutality everywhere from the Jim Crow laws to the civil rights movement to the mass incarcerations in prisons and psychiatric hospitals that we see today. Now, with regards to prevalence, while Black families often believe that their children are overdiagnosed with ADHD, unfortunately, the opposite is true. Data shows that Black kids are more often undiagnosed, misdiagnosed, or underdiagnosed than white kids, and therefore are less likely to receive interventions and accommodations that they need. The lack of which significantly alters the trajectory of their lives in a negative way. It is well documented that white society sees Black children as older and less innocent and gives more negative attention to their challenging behaviors and symptoms, especially ones that involve impulsivity and hyperactivity. Without an accurate and proper diagnosis, behaviors that are deemed by authority figures to be problematic will often be misinterpreted by school and law enforcement personnel as defiance and cause the child to be characterized and labeled as violent or a bad kid. And those children face elevated rates of suspension and expulsion from school and wind up in the school to prison pipeline, which disproportionately affects Black, Indigenous, and people of color. These same negative effects are seen with the underdiagnosis of ADHD in Black children exist in regards to bipolar disorder as well. Despite the fact that rates of bipolar disorder are the same among Black Americans and as they are among other Americans. And Black Americans are less likely to receive a diagnosis and treatment for bipolar disorder. And while misdiagnosis is common in people with bipolar disorder, it is particularly true for Black Americans. And in a 2018 review of research, researchers found that Black people with bipolar disorder are much, much more likely than white people to receive a misdiagnosis of schizophrenia. Additional research suggests that other historically more marginalized groups may also face barriers to diagnosis. And in a 2003 study, researchers found that Latinos with symptoms of psychosis were more likely than European Americans to receive a diagnosis of major depression. This is not a fate that we can leave to anyone, given the fact that these disorders are well understood and the research and academic community know that there are treatments available that can bring about stability and recovery for children, adolescents, and for adults with these disorders. So thank you all for being here with us tonight. I appreciate your time and attention over the last, hour or so. This list includes the articles and the information that tonight's presentation was drawn from. Please remember that CMHRC has comprehensive services and programs to support families as well as providers, including our professional discussion groups. We have a 6-month-long professional discussion group that is starting in May. It will be on, I believe, the second Tuesday of each month for 6 months. Once a month, providers from an interdisciplinary group of providers will meet for 90 minutes to discuss difficult cases around bipolar disorder, how it presents in children, and the challenges faced in diagnosing and treating it. You can get information about that series on our website under professional development discussion groups, and sign up to be a part of that series. At the end, any provider who has completed the 6 sessions with us will be added to our national referral network, so that when families come to us looking for providers who understand bipolar disorder in children, we are able to provide your name if you are in their area. You can also please consider making a gift to CMHRC. As I said, May is Children's Mental Health Awareness Month. It is the month of our first fundraiser of the year. If you enjoy the free resources that we offer, we would like to encourage you to make a gift. If you find yourself at our webinars and clinical seminars every month, we ask you to consider a recurring gift to help subsidize the fees and costs that go along with the production of these seminars and webinars. If you would like a certificate of attendance or completion, again, please look for the link to request that certificate in the follow-up email, which Zoom will send to you tomorrow. If 24 hours from now you do not have that email, you can email learning@CMHRC, and we will send you a link to that certificate request form, which we need everyone to fill out. So now what I'm going to do is I'm going to, again, thank everyone for coming, and we're going to switch to the Q&A. So I'm going to stop my screen share and invite my clinical director, Jennifer Sevick, on screen with me to talk about what questions have come up during this session that need to be addressed. Jen, hopefully you can join me. Hi.
Yes, hi. All right, so first questions I'm going to take care of that came up a lot and people said that they have to go, so I really want to get those out of the way, and then we'll get to the meat. A lot of people wanted to know if they could have access to the slides.
So the way that works is we can give you access to the slides, but there's a fee for that. And you need to sign something that says that you will not republish them as your own. And of course, the slides will also contain information on how to access the original articles. So yes, if you would like a copy of the slides, please email learning@cmhrc.org. And there's a small fee for the preparation of the slides and the distribution. So you can reach out that way.
And then
Also,
there,
wait, I
sorry.
just want to say one other thing about that. This presentation will be made public on June 1st on our YouTube channel. CMHRC members who have a recurring monthly gift, they have access to it starting May 1st, 30-day priority access to all of our educational videos, webinars, seminars, and everything that we put out. So that's another way to get access.
We had several questions about how can they have professional consultation, either diagnostically or they had mentioned sort of very specific cases. So can you talk about the different ways that they can go about doing that very briefly?
Sure. Well, the first way to do it would be to join our professional discussion group. As I said, we have one starting in May. It goes for 6 months. Those are opportunities for interdisciplinary groups of providers to come together and essentially get peer supervision. It's confidential, it's protected. You're able to come and ask for, present your cases, do case conferences, get alternative perspectives, suggestions on treatment interventions. You can talk about things you've tried that haven't worked, things that you've tried that have. You can share your knowledge and experience with the group, as well as receive the benefit of the knowledge and experience of the rest of the group. So those start May 14th. That's a 6-month program, runs once a month, May through October. We'll be starting another one shortly after. We keep them in rotation. So that's one way. A second way is to use our community advocacy program, where we'll meet with you for an hour for a flat fee for our professional services, where we will do one-on-one case consultations with you. If you are in need of a more substantial uh, case conference, for example, you need consultation on to determine whether or not the diagnosis you're coming to is correct. If you need additional documentation to support it for insurance claims, if you need additional resources for supporting the family by giving them information on the symptoms, the presentation, accommodations, and that sort of thing, we have a more comprehensive diagnostic consultation program, which you can get information about on our website. And that is for families as well as for providers. So you can have sort of an ongoing opportunity for case conference with a group of clinicians in our professional discussion groups. You can have a brief one-on-one session through our community advocacy program, or you can have a more substantial and holistic and thorough examination of your client's needs through our diagnostic consultation, all of which you can find information for on our website.
All right, thank you for that. And then, okay, so we had several questions about screening for pediatric bipolar. What are the screening tools that are most popular and the most accurate, and how can they assess those? A few questions on like sites to get those. And I wanted you to be able to answer that because some of those screening tools don't belong to us, and there is a fee to use some of
Right.
those.
Absolutely. That's a great question. So in our clinical seminar last month on bipolar disorder, which again will be available to the general public starting in May, we talked about the specific screening measures. So I'm not going to go into the same level of detail that I did then now on that. But what I can tell you about two that have been proven. They have very high reliability rates and validity rates, 96%, I think, off the top of my head. And they were developed by Dr. Demitri Papolos at the Juvenile Bipolar Research Foundation. He and his team came up with a 60-question survey for parents to take. It is called the Child Bipolar Questionnaire, and you can access it through the Juvenile Bipolar Research Foundation website, which is jbrf.org. And there is a fee that goes to Dr. Papolos for scoring that. But that is a very reliable measure. And what you can do as a clinician is you can request that your patient take the child bipolar questionnaire. They do it online at home. You don't administer it, and then have it scored and bring you the score sheet. We specialize in this, and part of our diagnostic consultation is helping you understand that score sheet, helping you understand what the answers on the individual questions means. I worked with Dr. Papolos for many years at the Juvenile Bipolar Research Foundation, so we have the ability to support clinicians as they use those tools. The second tool that's available through JBRF is the Janie and Jeffrey Illustrated Interview for Children. Again, this is an at-home tool, but what makes it unique is it's a tool that's devised for the child to take. And obviously, a parent may have to sit with them while they do it, click the buttons on the computer screen. But it's designed in a way to have cartoon-like drawings that show a representation of the symptom that the question is asking about, and then ask the child to rate it on a Likert scale, so that it's either, they never experience it, they experience it sometimes, frequently, or all of the time. And that gives special insight to you as a clinician as to how this disorder is manifesting for the child and what levels of dysregulation and distress it's causing. So we do recommend both of those. They are really wonderful measures that clinically can help you clarify the bipolar diagnosis in children. And again, I want to reiterate, help to rule it out or to rule it in. It's not the kind of measure that's going to, everyone who takes it is going to turn out to have bipolar disorder. It is a highly reliable and valid tool. And again, through our diagnostic consultation, we can help you understand the score sheets and the questions and the answers and how to use that information in designing treatment interventions.
All right, so now we're going to get into the meat of the questions here. And it says, can teenagers, I love this question, can teenagers have tantrums just as much as younger children? And I just want to say thank you for the person who asked this question. That is brilliant.
Absolutely, teenagers can have tantrums, and so can mommy and daddy. There's no age limit on tantrums, but the thing about the bipolar tantrums, and also very specifically on the fear of harm phenotype tantrums, is that they last for a very long time. And as Dr. Popper pointed out, those tantrums, they last longer in terms of duration. They are more intense, and they persist after the period of time developmentally where you would expect tantrums to start to fade. And so teenagers can have tantrums. The thing is that we always have to remember that all of the symptoms are going to look a little different in the different developmental stages. So, for example, uh, hypersexuality in a 5-year-old is going to look very different than hypersexuality in a 15-year-old, which may be very different from hypersexuality in a 25-year-old. So yes, teenagers can have tantrums, but what that tantrum looks like may be a little different than what you saw when the child was 2 or 3 years old. Jen, do you want to add anything to that?
Yeah, I actually wrote this into the question, so I don't know if I sent it out privately to that person or that if everyone could see that answer. I was trying to type as fast as I could. But so usually with children, what's happening is that you're going to see that they have mixed mood episodes. Almost most of the time, I won't say all the time because there's no absolutes, but typically what you're going to do is you're going to see that depression and you're going to see that hypomania or mania. They're going to be superimposed on each other. And so that's what you're going to see. And I noted that they're either going to have what people are used to, which is those aggressive outbursts, but just as much as they could, and this is what I learned from Elizabeth, was yes, they have aggressive outbursts, but they can also aggressively shut down. And so when they're done, they're done. They're just immovable. They're inflexible. It looks like extreme oppositional, extreme defiance, like they're not listening to you, like they have just checked out, and they have, but it's aggressively shutting down.
Yeah.
All right. So the next question that we have, I also love this one. What about symptoms of inattentive ADHD? We spoke a lot about hyperactivity versus mania. And so why didn't we mention for the child who has inattentive ADHD, does that align necessarily with any of the symptoms of bipolar?
That's a good question. And yes, Dr. Popper, he does address that. He talks about the difference in attentiveness as it relates to motivation. And so a child with ADHD is going to be equally inattentive, whether it's schoolwork or a TV show that they want to watch. I've heard from a lot of teenagers who with ADHD that they have to watch the same TV show or movie multiple times in order to be able to actually retain everything that happened in the movie, because they're watching the movie and their mind is wandering. Something in the movie triggers a thought, which then becomes a cascade of inattention, and they come back and they're like, oh, I don't know what just happened in the last 10 minutes of the movie. That is something that tends not to happen with bipolar disorder. That with bipolar disorder, inattention can be overcome with a concerted motivation. There can be a hyper focus with the bipolar disorder, and that hyper focus can lead to not just internally in their minds, but it can also lead to their behaviors being so hyper focused on completing a task that that inattentiveness is absolutely not present. It's the opposite. They go into what we call mission mode, and they become fixated on completing a task or finishing something or achieving something. And that inattentiveness is absolutely not there. It may reappear in another context, but it can be overcome with motivation.
And I want to add that we talked about this with Sarah Schley, who was our guest for our last book club with Bipolar 2. A lot of people who are, oh goodness, they are highly successful individuals, right? They are go-getters. They're just seen as super achievers. And so when we're looking at that, we want to be very mindful of, like, if you're seeing that and then you're seeing episodes of depression, you may want to look at, is bipolar a possibility?
Absolutely.
Yeah. All right. So there's another great question of rates of bipolar. The author of this question noted that it seems to be highly heritable. Do we have sources or resources on the rates of bipolar? And I'm just going to add that if there's one parent and then there's two parents, what do we know about
Jen, I'm going to let you answer this one.
that?
You are the expert on these statistics.
Well, actually, the funny part about that is, like, I had a mind block because NIMH actually does have the exact statistics, and we've done these before. So if you've seen any of
They're
our previous
they're in
ones,
the webinar from, or the clinical seminar from last month on bipolar disorder.
but yeah, yes, it is high. If you take it by itself, you go, oh, that doesn't seem very statistically high, but it's based out of the total population. So it is extremely high. But once you have two parents who have a mood disorder, whether it's bipolar and major depression or bipolar and schizophrenia or some other mental illness, that chance of heritability goes up significantly. And those risks, I do know, for substance use, for alcohol use disorders, if you have one parent who, if you're diagnosed with bipolar, there's a 60% chance that you yourself are going to have a substance use issue. And I think for bipolar 2, if you are diagnosed with that, it's like a 40% chance. And so this is why we want to catch children really early, because if we catch them and we know they have a family history, then what we're doing is we're decreasing their risk for the negative outcomes, because it doesn't have to be this way. If we catch it early, we can really decrease all of their risk factors.
So I just pulled up some of the statistics. 50% of mental illnesses begin before age 14. Bipolar affects 3% of all children. 1/3 of the 3.4 million children and adolescents diagnosed with depression. may actually have juvenile onset bipolar. There's over 1 million children and teens already diagnosed with bipolar, so that would be in addition. 7% of children receiving outpatient psychiatric services have bipolar disorder, and the estimates are that those numbers are much higher for those who are in inpatient facilities. And I believe that it's something like a 15 to 30% chance that a child will have bipolar if they have one parent who has bipolar disorder, and that goes up to around 70%
Yeah,
if they have two parents who have bipolar disorder.
right.
Um, so, yeah, I mean, don't get us started. There are a ton of other statistics we could throw at you about this,
Uh,
but it's
I,
really important to catch it early.
yeah. And one other one that I just read today, Ken Duckworth, NAMI put out a book and published it, and it's called You Are Not Alone. And in there, they talk about by the time a person is between 23 and 25, two-thirds of them experienced their first episode around like when they were in teenage years. So it does exist, it does happen, and it's so important to catch that early. The next question that we have, again, these are such brilliant questions. But the next
I think
question
that
is,
all these people who wrote these questions should absolutely be coming to our professional discussion groups, because
I know
wouldn't that just make them so dynamic and exciting?
it was great. It was, can a non-stimulant trigger a bipolar episode? Love that question.
So it's not just medications that trigger bipolar episodes. Lots of things can occur that will trigger a bipolar episode. I don't have a specific list of medications that are risks outside of some of those stimulant medications, but substance abuse, recreational drugs can trigger bipolar episodes. Emotional stress. There's so many things that could trigger. Trauma can trigger. I feel like, I mean, that's a whole other seminar that we're going to be doing later in the year on trauma versus bipolar. But someone can have a genetic predisposition for bipolar disorder because it is hereditary, and then have it emerge as a result of trauma. There's a lot of arguing that goes on in the community around the idea that, like, well, kids don't really have bipolar, it's all trauma. Well, again, it can be both. They can have a genetic predisposition for something and have
Mhm.
the trauma come along and trigger its presentation, its activation. So I don't have a list of medications, but generally speaking, whenever there's a family history of bipolar disorder, you want to absolutely avoid the stimulant medications, and you want to avoid SSRIs, because the SSRI medications that are used to treat unipolar depression can trigger manic and hypomanic episodes as well. So, always talk it over with your provider ahead of time if there's a family history of bipolar, to avoid the stimulants and the SSRIs.
Yeah, and I do know of cases of children who cannot take even non-stimulant medication
Oh,
that
absolutely.
actually, yeah, that can for them be very activating for irritability, aggression, depressive symptoms. So it's really, anytime you're talking about medication and you're talking about is there a mood disorder, you need to be very, very mindful and very careful every step of the way. All right, so then we have another question of sexual awareness of youth in terms of hyperactivity or hypersexuality. How can you distinguish that between, like, is this part of like a symptom of bipolar, or did something happen to them? Was there any kind of sexual trauma or sexual abuse?
Well, Jen, I know that you can speak to this as well as I can. I would say this: any provider obviously wants to do their due diligence to ensure that that child had not experienced any sort of sexual abuse. Uh, Period, full stop. That said, the hypersexuality that goes along with bipolar disorder is not necessarily in any way, shape, or form connected to sexual abuse. And kids who have bipolar disorder can experience hypersexuality and express hypersexuality without there ever having been any sexually traumatic experience. Sex we live in a culture that thinks of children as being asexual, that sexuality doesn't emerge until puberty. But that's absolutely not true. Children go through a very normal process of discovering their bodies, of understanding what sensations their bodies have, and can experience all of that um, independently of another person. Sex is one of the basic drives that we have as humans. And so, what happens with the hypersexuality is that there are uh, there's an intensification of that, and a manifestation of it that is not typically seen in kids who don't have those kinds of disorders. So, Jen, I know you've used some examples in the past of hypersexuality as it could be seen in young children. Do you
Yeah.
want to share some of those?
So it's not always what people think it is. It can just be like petting someone. You can have like a 6-year-old or a 7-year-old just scooting too close to someone they think is, that they're kind of having these feelings for. They're petting their hair. They just want to hold their hand. A lot of people think, oh, that's cute. Or and in reality that they're really kind of testing those boundaries and they're feeling those things. We're just not really aware of them, a lot of people. And so when you're asking and if you're a provider, being aware that hypersexuality, it just depends on your age and your development. And it can, also be more aggressive than that. And so you just have to be able to ask those questions and be aware if there's a family history, be aware if there's other symptoms that this can be. A hypersexuality can be. And I don't know many instances where hypersexuality was the only symptom that was presenting itself. So, in existence with other symptoms, I would definitely not be so quick to think that there may have been abuse. We want to rule those out, as Elizabeth said, full stop. And we want to keep in mind that it could be a symptom. And the other part of that is, bipolar, the limbic system is the primary system that is like impacted. And our hypothalamus helps with hypersexuality. And so we're seeing it's misfiring in a lot of ways, that it's impacted in a lot of ways. And that is one of those ways that it is impacted. So it's very much seen in quite a few children who are living with bipolar. Not always, but it can be there.
So, Jen, I
Um,
just want to point out that technically our time is up. We've hit the 90-minute mark, and I want to just say thank you to everyone again for being here. If you need to go, we certainly understand. If you want to stick around for a few more minutes as we go through a couple of more questions, that's fine. We will full hard stop in 13 minutes. And any additional questions that haven't been answered, again, I really encourage you to join our professional discussion groups, because this is all the stuff that we talk about face to face, interacting with our colleagues on every month. So Jen, let's see maybe one or two more questions.
all right, so we have another question. How do you differentiate between ODD when they're being oppositional and defiant, but they do not have bipolar disorder?
Um, I'm not entirely sure I understand that question, because if it's been determined that they don't have bipolar disorder, what are we differentiating?
I had answered this question. It said that you stated that kids with bipolar are not trying to be defiant or deliberately oppositional. However, the presenter, Elizabeth, states the opposite in differentiating between ADHD and
Ah,
bipolar.
okay, I understand the confusion now. Okay, so the child with the symptom that they are living with is pushing them to be oppositional, argumentative, defiant, challenging, hostile. They do not want to be. It is the result of an involuntary symptom. And so that's the distinction. When Jen says they're not doing it on purpose, and then the presentation says that that's what they're seeking, the difference here is that we don't, as I said, we don't view that behavior as voluntary. We view that as an involuntary symptom. And so, yes, the symptom is pushing them to be provocative, but that's not a conscious intention. That is the symptom at work. And so that's the difference.
All right, so let's see here. I'm scrolling through the question. Thoughts on marijuana use contributing to the development of bipolar?
I don't think that we're qualified to answer that question. It's a fascinating one, but we don't have the research at our disposal at the moment to be able to answer that in any meaningful way. So that is something we could certainly look into. We know for a lot of kids, I mean, what we do know is that for a lot of kids who go undiagnosed and untreated, when they uh, get to an age where they have access to illicit substances or recreational substances, they often develop substance abuse disorders. I think, Jen, correct me if I get this wrong, but like 40% of people who have bipolar disorder develop substance abuse disorders. I don't know what the statistics are on what percentage of those folks are untreated. My clinical instinct would be that the more people who are untreated for bipolar disorder are going to develop the substance abuse. There's a longitudinal study out of the Juvenile Bipolar Research Foundation on the use of ketamine for treating the phenotype fear of harm that actually showed substance use decreased when effective medication was introduced. So it's a very complicated subject, and it certainly warrants additional examination.
I do want to get to before we leave. There was a question, and I'm sure that others that have that question as well. They're finding that in their area, they don't have anyone willing to diagnose or even look at bipolar. And so, how does someone go about doing that if they suspect that there is bipolar? And whether you're a therapist and you're looking for a doctor or you're a parent, how do they go about doing that?
It's tough because there is this stubborn uh, misinformation that kids can't have bipolar disorder when they can. And so, that's one of the areas where we work very hard to plug in those holes and bridge those gaps. And so, if you're a family and you need a provider who can understand bipolar disorder, come to us. Our community advocacy program specifically works around providing support and psychoeducation for your providers so that they can have the information that they need in order to understand the disorder and to provide the effective treatment. If you are a provider and you're thinking, wow, this is a need that I see, but there's no one in my area who's trained in this, get trained. Come to our professional discussion groups. You know, work with us, use our diagnostic consultation services so that you can become fluent in bipolar disorder in children. We're here as a resource for providers as well as for families because we recognize that the way to bridge that 10-year treatment onset delay that exists for kids, the way to bridge that is to get more providers trained. So come to us and work with us because we are, that's why we're here.
All right. And so I think Elizabeth,
There's
do we have it?
one question here that just pops up that I want to get to because I just think it's great and it's all the way at the bottom and you probably haven't seen it. And that is, how helpful is play therapy in helping manage symptoms of bipolar in children? So we always talk about treatment for bipolar disorder as a three-legged stool. You need all three legs because if one's missing, the stool is going to fall over. And those three legs are medication, therapy, and lifestyle interventions. Now, the thing about therapy is children who are symptomatic are not going to be able to respond to what you've probably been most familiar with, which is cognitive behavioral therapy interventions. Kids with bipolar disorder, because they've likely been disciplined for their symptoms, because they've likely spent years being misdiagnosed and having medications that made things worse, it's going to be really hard to trust you as a provider. And so that period of rapport building, that period of emotional connection with the kid is going to be prolonged. It's going to take a lot longer. And a good therapist is going to understand that you're not going to be skill teaching with a kid with bipolar. You're going to be rapport building, and you're going to do it as long as it takes for that kid to feel safe with you and to trust you. And you're going to respect their boundaries. And play therapy is a really great way to get at that, as are things like art therapy, so that they have an outlet for their feelings where they are not feeling judged. And parents sometimes will come to us and say, I think my kid's therapist is, I don't know what's going on. They just play checkers every week. Good. Because over a game of checkers, that kid is building a sense of trust, a sense of familiarity, a sense of predictability, a sense that they're safe. And it's over that activity that they are more likely to disclose and share how they're doing than if they're being forced to engage in some kind of talk therapy or skill building that they are only marginally capable of due to symptom presentation.
And I saw in here there was a question between borderline personality disorder and bipolar. So I just want to mention that later on, we will be having that available. So please check out our website to be able to register for that. And I believe it's not until this summer or
It's
fall.
probably, I can't remember either. We post this calendar of our webinars and clinical seminars on a 3-month in advance basis because we do have a lot of turnover. For example, as I said at the beginning, we had this wonderful opportunity present itself that Dr. Georgia Eid, who wrote the book Change Your Diet, Change Your Mind, is going to be doing a webinar with us in July. Rather than have folks scheduling for something and then having to juggle it around, we hold our announcements so that we can get stuff lined up that people are interested in. So yeah, check back to our website regularly under the webinars page or the clinical seminars page, and you'll see everything that we have coming up over the next few months. In May, because it is Children's Mental Health Awareness Month, our webinar is going to be on the lived experience, talking with families and providers on how to create connection and community for families who are living with early onset mood disorders and bipolar disorder. And in May and June, we are doing this fantastic 3-event series with Dr. Papolos, author of The Bipolar Child, and he's going to come in and do a 3 series with us on the history of the identification of the fear of harm phenotype, which is now being called thermoregulatory sleep dysregulation disorder. He's going to do a whole session on it, the identification of its treatments, the longitudinal study that demonstrated its effectiveness, the treatment protocol, and he's going to do a live Q&A for prescribers and a live Q&A for all other clinicians. So that is an absolute don't miss. It is free of charge. The sign up should be up within the next couple of days. Check out our website and make sure that you sign up for that because that's going to
I
be
can't
fantastic.
Yeah, I can't emphasize that enough. Like he is regarded as one of the premier leading experts on pediatric bipolar. He was there were several, but he was one of the first like to say, hey, we really need to look at it because it can exist in children where previously it was not thought otherwise. So it really is a don't miss.
Yes, and someone asked to repeat the name of the book. It's The Bipolar Child. It's in its 3rd edition, and it's written by Dr. Demitri Papolos and Janice Papolos. And you can find it on Amazon, and you can find a link to it on our website's book club page because we did do that book last year. So again, if anybody for those who are still here, thank you so much for being with us today. We really appreciate the opportunity to speak with you. We hope that we will see you in our professional discussion groups, in our book club, and at our other events. Our community is growing, it is strong, and we are here to support providers as well as families who are living with these disorders. So thank you so much for being with us.